This next video talks through the renal patient, and this is one of the easiest ways to pick up nice simple marks in gastroenterology or abdominal examination. So what you get again as a patient, we've discussed the general abdominal examination previously, so we'll talk through specific features of anyone that you see who's got either signs of a dialysis line or a transplanted kidney or signs of other renal replacement, or you may be told that the patient's got on dialysis. So straight away, if I was in an endoscopy, this patient comes to the hospital and receives regular dialysis, please examine their abdominal system. I'll start again from the end of the bed, but for this purpose I'm just going to talk through inspection from the end of the bed. The commonest causes of chronic renal failure in the UK in any age, including the young, would be the following. You think about diabetes, type 1 and type 2, hypertensive renal disease, and glomerulonephritis as the main three causes. So think of those things in your mind. Really, you're going to cover the vast majority of chronic renal failure. So remember, diabetes, hypertension, glomerulonephritis. In a young chap like this, probably glomerulonephritis. Think about hands. Any signs of diabetes? Yes, very simple. Duodenum's contracted, but more importantly, the small finger, the small pinprick marks from the patient checking their blood glucose. You see multiple little dots across the finger edges. It's a really astute observation, and the examiners will be impressed if you pick out something like that in any exam, be it a membership exam for surgical or medical finals or anything else like that. Looking for signs of scars or dialysis, so these sort of sites where you'd see a fistula scar. Patients may have numerous fistulas. There's two key questions you need to ask yourself. First question is the fistula actually working? You always ask the patient in a renal exam, do you mind if I just palpate or just gently feel across the fistula? Just use the back of my hand. Just feel across the fistula. If it's buzzing and humming, it means that arteriovenous connection's working very nicely, and it means the fistula is actually working. The second question you need to ask is the fistula being used? Now, to use a fistula, dialysis is generally 3 times a week. Stick a dialysis needle into one of these. It's a knitting needle-sized needle that goes straight into the fistula. So if someone's having dialysis through a fistula, you need to think, hang on, are there signs that the fistula's been punctured recently? If there aren't, that means the fistula isn't being used. So if you've got a renal patient who's got a fistula, if it's not being used, it means one of a couple of things. Either, one, there's another fistula which is being used elsewhere for renal replacement, maybe in the other arm, maybe in the leg, maybe in the groin. 2, he's having another form of renal replacement therapy. Now, other things could be either peripherally inserted central catheters, maybe a PICC line coming in that's been inserted either in the antecubital fossa or tunnel lines that are being used for hemodialysis, so venous-venous dialysis. Or is he having renal replacement through some other means? Is there a renal transplant? Again, thinking about the groin, looking for a transplant scar. Okay, and that, or the other question is, does he have end-stage renal failure which hasn't yet required dialysis? So maybe this fistula has been put in there in place in the anticipation of dialysis being needed in the next few months. So the renal patients are either having renal replacement, or they don't need renal replacement because they're either just on the cusp of needing it, or they've had a renal transplant. Okay, so moving on, I've highlighted some areas of the neck here. These are signs from previous central venous access and scars that you can see on both sides of the neck. But don't forget to neglect the face in the renal transplant patients. You may notice a lot of facial acne in these patients. They may have a cushingoid faces, and there may be other features of steroid use, such as, for example, steroids around the bed, so prednisolone tablets, or and so signs of prednisolone use commonly used in most patients who've had a renal transplant, and then other immunosuppressants for renal transplant patients like cyclosporin, probably the commonest still used in the UK. Can I ask you to open your mouth for me, please? Looking for some characteristic features of cyclosporin use, again, the acne and gum hypertrophy. Cyclosporin's got a number of side effects. It also causes a neuropathy, and hypertension. So these are all things you're thinking about to make yourself look good in an examination. So again, once you've inspected the face, you're coming back down. You can also think about rarer things for exams, things like tuberous sclerosis, associations of epilepsy, adenoma sevation, and other skin manifestations. You need to think about all these other different things as well. So again, looking at the abdomen, thinking about features such as scars, so signs of little scar here represents previous CAPD, or continuous ambulatory peritoneal dialysis. So patients get home at night time, they've got little ports in for the dialysis fluid that then is used to provide the renal replacement. Again, thinking about scars on the right iliac fossa, these are sort of areas where transplanted kidneys will lie, so they'll be transplanted in. It's important to remember that when a patient has a renal transplant, they normally leave the old non-functioning kidneys in situ, so they don't remove them unless it's cancer, or unless there's another reason to remove them. So for someone, if I saw scars here, left side of loin scar and a right side of loin scar, I might think about the removal of polycystic kidneys because of either size problems or because of recurrent infection of the cysts in the polycystic kidneys. When you're examining the abdomen in a renal patient, again, so the key questions are then, firstly, can you feel any enlarged kidneys? So if you can feel a single enlarged kidney, you need to think, is this cancerous lesion, mitotic lesion? Is this hydronephrosis, so an obstructed renal system, obstructed ureter and subsequently enlarged kidney? Or is it a renal cyst? Or the other differential is a single functioning kidney, so congenital reason why the patient only has one kidney and that hypertrophy of that kidney. So they're the main reasons why a single kidney would be enlarged. If you can feel enlarged kidneys bilaterally, almost always the cause is a autosomal dominant adult polycystic kidney disease, or ADA-PKD. Again, hereditary condition leads to end-stage renal failure, often by the 30s or 40s. Can be screened for using genetic or ultrasound criteria, associated with liver cysts, again, and associated with berry aneurysms and stroke. So they may give you an introduction. This patient's recently had cerebral angiography and has been found to have a cerebral aneurysm. Would you like to examine his abdominal system? Think, have they got polycystic kidney disease? If you can feel a liver that's enlarged, again, think about that. They may say the patient's got a family history, so it's autosomal dominant, so it's 50%. 50% of the children of one single parent will have the condition. So there will always be a family history in the majority of cases. So if you can feel bilaterally enlarged kidneys, if it's not polycystic kidney disease, you need to think, is it something else like amyloidosis or other rare conditions like von Hippel-Lindau syndrome with bilateral renal tumours. Thinking about the kidney itself, patients are very protective of the transplanted kidney, so you always ask if you can palpate around it. Don't percuss over it unless instructed to. But when you're feeling an enlarged kidney, you'll feel a mass that's reasonably superficial, unlike the kidneys which are retroperitoneal. Yeah, so superficial mass. Now, normally it shouldn't be tender. If it is tender, it's maybe a feature of signs of problems with the graft, such as rejection. So palpate the area. You can sometimes listen for, is there a renal bruit, so you can listen over the graft, as so, yeah. You can also listen for bruits of renal artery stenosis. But once you've examined the graft, you have to then draw some conclusions. So if they have got a superficial, smooth, non-tender, 10 centimetre mass, palpable, superficial in the left iliac fossa, then you think it's likely to be a kidney transplant. You then comment on the other features. So, for example, if there's a fistula which is being used, it means that this graft may not be functioning normally. There may be other features. There may be a small puncture around the graft site, a sign of a recent renal biopsy. So these are all things you need to think about in the renal patient. And when summarising your findings, you need to be nice and clear and comment on all of these things. I note the fistula in the right forearm, which has features of recent use, suggesting current renal replacement therapy. I also note the presence of bilateral palpable masses in both flanks, which are ballotable, large, extending from the right costal margin down to the right iliac fossa, and identically so on the left side, along with the scar in the left iliac fossa with smooth, non-tender 10 centimetre mass superficially palpable below this. All of this finding suggests a diagnosis of autosomal dominant adult polycystic kidney disease with a previous left-sided renal transplant. The fact that the patient appears to be having current hemodialysis suggests that the current transplanted graft is not functioning effectively at this time. And once you've done all those things, you can then leave yourself open for questions about the patient's condition.